Yeah, okay. Dear Chair, ladies and gentlemen, basically I would like firstly to thank ESOPRS and especially Yanis and George for the kind invitation. In the next 6 or 7 minutes, I'm going to just debate with Jane on the issue of basically external versus endonasal DCR, in which I'm going to review 7 key points briefly based on the literature review and our experience, even though we don't have that many papers comparing these two procedures together, just 23. When it comes to randomized clinical trial, you would see just one and one meta-analysis. So let's get started with the success, especially when it's targeting the pondo and functional nasolacrimal, because the other etiologies is not covered by the endo. When you go to the literature, consistently, you will find much higher success for the external DCR, and as you see, the osteum size in the comparative report recently published shows almost twice larger osteum size for the external DCR, and in only one randomized clinical trial, you would see again higher success rate for external DCR, even though it was insignificant. We compared our cases with endo versus external DCR, in which we found significant difference between the external, favoring the external DCR in terms of the anatomical and functional success. And the only article published on the functional nasolacrimal duct obstruction comparing these two procedures, Jane reported 100% success for the external DCR, but less for the endo. And that's why, in a survey amongst ESOPRS members, the majority chose external DCR mostly for its higher success. How about the cosmesis, which has been blamed against actually external DCR? As you see there, the end of any procedure is the satisfaction of the patient. And in this article, you would see 100% satisfaction at the end of the basically follow-up for both endoscopic and external DCR. We basically, when the external DCR performed by different level of surgeons, basically we found 1.8% of visible scar, whereas when it is performed by the lacrimal surgeon, no visible scar was found in our experience. These are a couple of examples, just day 1 after operation, bilateral mini incision, external DCR. When you remove the stereostrip, nothing is visible. In 6 weeks' time, it's back to normal skin. And the other example you will see here, the day after removing that, nothing is visible. How about the equipment and cost? Jane would require very sophisticated instruments like beam splitter, monitor, everything, to come across with what just simple DCR procedure, whereas we need just basic instruments available everywhere to go. How about the field of view? They have a very narrow, limited field of view indirectly through the monitor, whereas we are paranomically viewing a very large field. That's why at the end of the procedure, we have a very nicely sitting flaps together, relying on primary intentional healing rather than first putting the light over there to find out where we are first, then go ahead and in the mess of bleeding and everything, you have to remove everything to rely just on secondary intentional healing. How about the time of procedure and the recovery, which has been somehow favoring endo DCR? I'm going to show you just our procedure in here. If you follow the time on the bottom right, you will see in 32 minutes under local anesthesia, you can easily perform on a young lady external DCR with no problem in there, and you are ending up with no skin suture. And this is the day after. This is the December 11 on the time of the procedure. And then you'll see the day after, everything is back to normal. No swelling, no bruise, nothing is over there. Very fast recovery. In 6 weeks' time, even you don't see anything in there. And if it comes to another young lady, again, you see the September 1, the stereostrip, they're putting makeup on, back to workplace, no any hustle and bustle after external DCR. And on the day 1, you don't see anything on the incision side. And if you go 6 weeks later, nothing is visible. This is when we are removing the tube. You see nothing is visible over there. How about the number of post-op? Consistently, literature says follow-up time is more frequent for the endo-DCR rather than external DCR. And the complication, again, either it has been the same for both, or is, if you see there in the comparative study, 10% more for endo-DCR. But this is not the important. The important thing is who is going to take care of your complication. If you are doing the surgery, it is you to take care of your complication. Whereas if anything happens inside the nose, then you have to go kindly ask somebody else to come and take care of your complication, which is a little bit difficult. Just let me summarize that. On the 10 score, we have here, I have put 2+ for the success, but 1 for the rest. I would say 9 out of 10 for the external DCR, that's why it's green to go. But for the endo, it is just 2 out of 10, raises the red flag. And remember, a lost flag, a small osteum, external DCR is usually considered a very good endo DCR. Remember that. And having debated that, and we know the external DCR, will you back to the slide, please? So that
No, we won't.